Good morning and welcome to the session or class on anti-thyroid drugs. In the previous class, we described or discussed the actions of the thyroid hormones and the treatment of hypothyroidism. In today's class, we will be discussing anti-thyroid drugs. These are the drugs used in the treatment of hyperthyroidism. So how are these drugs classified? This is the part of your 10-mark question. So at the end of this session, you will be able to classify the anti-thyroid drugs and describe the mechanism of action, uses, adverse effects, contraindications and precautions of the two major groups of anti-thyroid drugs used, namely thioamides and radioactive iodine. You will also be able to describe the treatment of thyrotoxic crisis, also called thyroid storm. Now, how are the anti-thyroid drugs classified? We have the thioamides, which includes propylthiouracil, methimazole, and carbimazole. The second group, which are very rarely used, are the anion inhibitors, namely potassium perchlorate, thiocyanate, and pertechnate. Then we have iodine and iodides, which includes Lugol's iodine and potassium iodide. And radio-labeled iodine, which includes iodine 131 and iodine 123, the most widely used being the isotope 131, and beta blockers, namely propranolol. Coming to the thioamides, propylthiouracil is usually a 5-mark question. We will describe the mechanism of action, uses, and adverse effects. The mechanism of action of the thioamides. They inhibit the key enzyme in thyroid hormone synthesis, namely peroxidase. So the peroxidase catalyzed reactions, that is oxidation of iodine and incorporation of iodine into the tyrosine residues and formation of MIT, that is monoiodotyrosine and diiodotyrosine, which finally form T4 and T3. In addition to this, of the three, propylthiouracil also inhibits the peripheral conversion of T4 to T3. This is important in the treatment of thyrotoxic crisis. The usual dose of propylthiouracil is 100 to 200 milligrams per day. Methimazole is given in the dose of 10 to 20 milligrams per day per oral, and carbimazole in the dose of 30 to 60 milligrams per day. All these are given orally. Now the point to note here is the onset of action with these drugs is slightly delayed, maybe 10 to 15 days, because whatever pre-formed and stored thyroid hormones are there, those need to get used up. The adverse effects of thioamides, since these drugs inhibit thyroid hormone synthesis, the expected adverse effect is hypothyroidism and a rare but severe form of agranulocytosis. Other minor adverse effects like skin rashes and skin pigmentation, nausea, headache, joint pains, hepatitis and nephritis. So the two important adverse effects of thioamide one needs to bear in mind is hypothyroidism and agranulocytosis. Coming to the uses of the thioamides. In Graves' disease, methimazole is used because it is long-acting, which is amenable to once a day convenient per oral dosing and is less toxic when compared to carbimazole and propylthiouracil. Then in toxic nodular goiter, though surgery is the mainstay of treatment, at least to control the symptoms and bring the patient to a euthyroid state, treatment can be started with methimazole. Before starting radioiodine therapy, that is to make again the patient come to a euthyroid state. Preoperatively to achieve euthyroid state. Now in an enlarged and hyperactive thyroid gland, the gland is very friable, that means very soft, it is highly vascular and it is large in size, which makes surgery a little difficult. So before posting the patient for surgery, about 15 to 20 days of treatment with methimazole makes the gland firm, less vascular and smaller in size. And in the treatment of thyrotoxic crisis or thyroid storm, propylthiouracil is the preferred drug because in addition to inhibiting thyroid hormone synthesis, it also inhibits the peripheral conversion of T4 to T3. The role of iodine and iodides in the treatment of hyperthyroidism is quite interesting. Now what happens as it is, there is excess production of thyroid hormones. So when iodine is given in the form of potassium iodide and elemental iodine, this combination is called Lugol's iodine. Now when excess iodine is given in an hyperthyroid state, what happens is, for a very short time, that is transient inhibition of iodine uptake is there by the thyroid gland, and it inhibits TSH control over the thyroid gland, thus decreasing the levels of T4 and T3. It also causes the gland to shrink in size, become less vascular and more firm. Now this effect of transiently inhibiting the release of thyroid hormone from the thyroid gland is called thyroid constipation. This they will ask in the YAR. What is the role of iodine and iodides in hyperthyroidism? So the role of iodine and iodides is they inhibit the release of preformed thyroid hormones. This effect is called thyroid constipation. A very frequently asked 5-mark question or a part of the main question is radioactive iodine. Mechanism of action, uses and adverse effects. Iodine 131, this isotope is what is commonly used. The mechanism of action, sodium iodide 131 is the salt given orally. It gets concentrated in the thyroid gland and emits alpha and beta particles. The beta particles destroy the thyroid parenchymal cells, which penetrates to 0.2 to 0.5 millimeters. So the damage caused to the thyroid gland is very, very restricted, and it does not damage the surrounding tissues. So this is one major advantage. The alpha particles do not damage the tissues, they just pass through the tissues. So this counting of the alpha particles can be used for diagnostic purposes. The dose of iodine 131 is 5 to 10 millicuries, which is given per oral. So the mechanism of action of radioactive iodine is the beta particles which are emitted by iodine 131 penetrates to a depth of about 0.2 to 0.5 millimeters and destroys the thyroid parenchymal cells. This destruction is permanent. Radioactive iodine is used in the treatment of Graves' disease and in patients who are unfit for surgery, that is thyroidectomy, or a hyperthyroid patient with pre-existing heart disease, in toxic nodular goiter, though surgical treatment is definitive, and in metastatic carcinoma of the thyroid. Coming to the advantages of radioactive iodine. It is economical. Compared to surgery, the cost is very low. It is convenient because radioactive iodine is given by the oral route. It can be done on an outpatient basis. There is no need to hospitalize or admit the patient. The other advantages are the risks associated with surgery, that is like scar formation, damage to the recurrent laryngeal nerve, and damage to the parathyroid gland are avoided. So since surgery is avoided, all the risks associated with surgery are avoided. The cost of surgery is avoided, therefore radioactive iodine is economical. Given orally, therefore it is convenient. On an outpatient basis, therefore no hospitalization is required. And once the thyroid parenchymal cells are destroyed, the destruction is permanent. So there is permanent control of hyperthyroidism. What are the disadvantages associated with radioactive iodine? Sorry, there is a spelling mistake here. Now the thyroid gland is destroyed permanently, which means the gland is no longer able to produce the hormones. So after radioactive iodine treatment, replacement therapy with thyroid hormone is required for life. Excuse me. Because whatever hormone has been synthesized and stored, that has to get exhausted. So the onset of action with radioiodine is delayed. It may take 1 to 2 weeks. Because it is a radioactive substance, it is contraindicated in pregnancy because it is teratogenic, and in young adults because it is carcinogenic. Iodine 132 isotope is used for diagnostic purposes. Now coming to thyrotoxic crisis or thyroid storm. This is a rare but serious medical emergency. So the treatment consists of general supportive measures and specific treatment. General supportive measures like maintain hydration with IV fluids, maintain fluid and electrolyte balance. Because the body temperature is going to be increased, antipyretics like paracetamol can be used or external cooling with alcohol sponging, and anxiolytics like diazepam need to be used. Propylthiouracil is given intravenous. In addition to inhibiting thyroid hormone synthesis, it also prevents peripheral conversion of T4 to T3. There is a typographical error here. Propylthiouracil inhibits peripheral T4 to T3 conversion and also inhibits thyroid hormone synthesis. Oral and intravenous iodides like lugol iodine can be given to produce the thyroid constipating effect. That is, they inhibit the release of thyroid hormones. And propranolol is given to control the tachycardia, to prevent dysrhythmias, and in addition, propranolol also has a role in inhibiting the peripheral conversion of T4 to T3. So here we have two drugs which are crucial in inhibiting peripheral T4 to T3 conversion, namely propylthiouracil and propranolol. To prevent adrenal insufficiency, hydrocortisone 100 milligrams is given intravenously. So this is a very frequently asked 5-mark question in pharmacology and in general medicine. Treatment of thyrotoxic crisis. So we have general supportive measures in the form of intravenous fluids, antipyretics and anxiolytics. Propylthiouracil to reduce or inhibit the peripheral T4 to T3 conversion and inhibit thyroid hormone synthesis. Iodides for their thyroid constipating effect. Propranolol to prevent dysrhythmias and inhibit T4 to T3 conversion. And hydrocortisone to prevent adrenal insufficiency. Thank you.